Thank you very much, and thank you very much for taking the time to attend this morning's session. I know we're up against the paperless NHS down the road, so the fact you've taken the time to come here either means the paperless NHS is never going to happen or that dementia is more important, but we will let you be the judge of that at the end of today. Really, the purpose of this morning's session is just to talk about a piece of work that MHP did with the Alzheimer's Society a couple of years ago, looking at the commissioning of effective... Sorry, I've got some technical issues. Might be a slideless. Sorry. There we go, finally, sorry about that. To talk about a piece of work that MHP did with the Alzheimer's Society a couple of years back now, looking at how dementia services could be commissioned within the new health system, and really looking at the commission of dementia services on the backdrop of the government's health and social care reforms. What we really want to do today is give you a bit of background to the new commissioning environment, talk about the report, but also really importantly, and what the really crux of the reason we're here today, is to talk about some of the recommendations and practical solutions that we came up with within the report, which can really affect the day-to-day lives of the commissioners out there, but also could be some useful recommendations which you can take back to the ground and the front line. Just before we do that quickly, I'll just introduce ourselves. I'm Ben Nunn, I'm an account manager at MHP Health Mandate. We're a specialist policy consultancy working across health and social care and working with a range of different organisations. We work with providers, commissioners and a lot of third sector organisations, including the Alzheimer's Society. We've done an awful lot of work in the past couple of years looking at dementia, particularly with the Alzheimer's Society. And I've most recently led a piece of work we've done with the Society looking at the concept of dementia-friendly communities and how that can really be translated at the ground and translating what David Cameron thinks into something which can actually be practical and actually a reality. I'm just going to quickly pass over to my colleague Richard Slogget, who's going to talk a little bit more about the background.
Thanks, Ben. I think before we start, it's actually very good being on first because we get to sort of set out what the challenge is for dementia and why we're all in this room today and why it is such a massive issue at the moment. I've put up 3 stats here, but I could have frankly picked lots and lots of different ones. 800,000 people is an estimated number of people with dementia in the UK today. The number in England is about 650, 700,000. So that is a significant number of people, not only with dementia, but also one of the things that often gets overlooked is the people who care for people with dementia and the costs and the personal experiences of those people as well. Rising up to about 1 million by 2021, so we're looking at a 20% rise in that time between now and then, so significant additional pressures as a result of that. 23 billion is the estimated cost of dementia to the UK economy each year. Now what I would say, and this is one of the key learnings from the work that we've done, is we can't just think of dementia as a health problem. It is a health and care and actually a societal issue as well. And the majority of that 23 billion cost comes from social care rather than the NHS. So one of the things that we did look at through the report and the research and from all those that we spoke to was we need to think about how across those traditional boundaries of health and social care that we can encourage and facilitate better joint working. And I think that's one of our key learnings from the work we have undertaken. From the research that we undertook, Baroness Greengross, who chairs the all-party parliamentary group on dementia, tabled a question which basically looked at the number of emergency admissions that the NHS was recording for dementia. What's interesting about this is it shows, first of all, that those number of admissions is rising, but actually it's a massive undersell of the problem. Because what we're seeing here is we're seeing a 12% rise, but actually that isn't particularly significant because actually what that doesn't take into account is people who are misdiagnosed, those who don't have a primary diagnosis of a dementia, they might be admitted for a reason. Their dementia may have led to them have a fall or a stroke. So there's a lot of additional things that aren't being captured through this number. But interestingly, the Telegraph ran this as a front page story just to show you how the kind of how dementia as an issue is resonating, even though actually it doesn't actually show the full scale of the challenge that we're up against and why the Prime Minister and actually the health and social care system is looking at dementia as the next cancer. So as I said, one of the key things that we found through our work was actually we can't just look at this as an NHS issue. It is an NHS and social care issue and even a broader societal issue. That brings with it challenges in terms of breaking down traditional barriers between health and social care and actually how we can get past that and how the reforms, whatever we think of them, how we can use those levers and mechanisms in the reformed structure to actually deliver better services. So hopefully that tees up Ben to talk a little bit about the research that actually we undertook and the expert group.
So I think Richard's set the backdrop about what the challenge is and what the challenge is for dementia and for commissioners of dementia services. But that challenge in terms of the numbers of people affected and the cost of the disease really came on the backdrop of a massive structural change to the NHS, and you will know better than anyone how much change and upheaval has happened over the past 3 years as a result of the government's health and social care reforms. Now, as Richard said, we can make whatever we want, we can say whatever we want about the reforms, but actually now we've got to make them work. And the Alzheimer's Society and MHP came together and said, actually, why do we start trying to come up with some practical and constructive solutions about how the reforms to the health and social care system can actually really deliver for people with dementia? So how we did that was we convened a roundtable event with some of the leaders within the dementia sector. And we really had a broad range of stakeholders around the table. We had the National Clinical Lead for Dementia, Alistair Burns. We had Jeremy Hughes, who's the Chief Executive of the Alzheimer's Society. But we also had representatives from commissioners, such as commissioners based in the South West, and providers, including Sue Ryder and Age UK. Now, one of the key tasks of that group was to come together and talk about the challenges, talk about the threats and the opportunities that lie in the reforms, but then actually come up with the solutions which can help to deliver on those on those threats. So the key recommendations and kind of key themes from the reforms kind of cover 4 broad areas. Firstly, looking at effective integration. So how can integration be delivered within the new system, and how can we deliver truly integrated care for people with dementia? Then looking about how can the dementia community and how can dementia really capitalise on the information revolution and actually improve the data out there for dementia to make it work for service users. Then around funding, so how can, in a time when there is no money left, the councils have had budgets cuts, but then the NHS is also facing its own financial squeeze, how can the funding arrangements for dementia be reformed in order to deliver better quality care? And then finally, how can commissioning be based on quality, but also actually what people with dementia and people affected by dementia want? Rich is going to talk about integration in information, and then I'll quickly run through funding and quality.
Integration. If anybody can give me a succinct definition of what integrated care means, I would be very impressed. The King's Fund has found something like almost 200 different definitions of what integrated care is, and everybody who you speak to goes, yes, we need to integrate services. And then you get to the conversation of, so what does that look like? And everybody gives you a different answer. I think integration is absolutely at the heart of this agenda of making care for people with dementia better, but how we go about delivering it is the really difficult bit. At a national level, Norman Lamb was here yesterday and was talking about integrated care pioneer sites. You know, those with short and medium-term memories will remember the integrated care pilots that we had under the previous government. By 2015, we're supposed to have integrated care projects in every part of the country, and we've got this interesting target from a government that doesn't do targets, that by 2018 there will be integrated care for everyone in all parts of the country. So there's a lot of national chatter around integrated care and a lot of work going on, but actually the key mechanism for delivering it has got to be local. Every local commissioner in this room nationally will want to do things slightly differently based on their population needs, their expertise, etc. And the local health and wellbeing boards are going to be absolutely critical to driving this change, bringing together public health, NHS and social care professionals and indeed other organisations to actually try and join up services at a local level. And there are signs already that that is actually working. There are some examples in the Dementia Challenge report of actually how these groups are now working together better, but there are still significant barriers, whether they be cultural or particularly funding, which Ben will come and talk on later. I think also the thing about integration is every time somebody talks about integration, they talk about a system or a structure, and they talk about whether it's primary, secondary care, horizontal, vertical. What people often forget is there is a patient or a user or a carer who is actually should be absolutely at the centre of any discussion around integrated care. A patient or a user doesn't care if their care doesn't care whether it's primary or secondary care who delivers their care, or whether it's social care or NHS. What they want is the right care at the right time. I was reading a story about a lady who is 90. She often has to go into A&E, but her care home won't provide her with support to go into accident and emergency services for a 4 or 5 hour wait before she is seen, because they're not paid to do it. So this old elderly lady will be sat in A&E for 4 to 5 hours on her own in a fairly stressful environment, and anyone who reads the newspapers or has gone to A&E recently will know it's a fairly interesting environment at the moment. And actually, that is an example of a patient or user falling through the cracks of the system because there is no joined up thinking between the two services. So I think it's always important to think about that patient or user or carer when we're having these discussions. And National Voices has done some really interesting work from an NHS perspective on this, which is well worth having a read of. The government loves integration because it means they don't have to talk about competition. Competition was an absolute disaster for the government when the Health and Social Care Bill was going through. It led to a lot of debate and discussion around what sort of competition looked like. So they fell onto this terrain which they're very comfortable talking about, which is integration. The government will always go back to integration, particularly when it's been attacked on the system. So if you look at the issues around A&E at the moment, what does the government talk about? It talks about integration, urgent care centres, etc., etc. So actually, this is right at the forefront of the government's agenda. So dementia can be a real exemplar for integrated care if we think about all the different touch points a user will have with the system. And frankly, there is no money, as Ben has said. We are in a really difficult spending period. Anyone from a local authority who's here today will, I'm sure, tell me afterwards that there is absolutely no money to do any of the service redesign or fantastic online, new innovative apps and all the sorts of things that people really want to do because they are facing such a huge pressure. The Barnett graph of doom is well known from a social care perspective about the rising pressures and the limitations in funding. So there is a a system imperative to actually think about new and innovative ways to make existing money go further, and that may be through things like joint budgets, which we will come on and briefly talk about later. The report we put out in 2011 had a number of recommendations in it. We're very pleased that 7 of those have been taken forward already, which is really, really positive. Some of these are designed basically to help the new system work better. Health and wellbeing boards will have a number of different representatives on them. We'll also have councillors who will actually have democratic oversight of local services and who may not have the best insights and knowledge on what dementia services look like. So actually upskilling people who will now have those responsibilities is going to be a really important challenge for the system. One of the things the NHS is very good at is assessing things and saying there's a problem. Where it's less good is aligning that assessment with strategy. One of the things the reforms does is it places this impetus to create joint health and wellbeing strategies for areas based on the Joint Strategic Needs Assessment. We're doing a piece of work at the moment which is looking at how strategies align with assessment, and what we're finding is very, very interesting. The Joint Strategic Needs Assessment takes a really huge amount of time for anyone to complete, all the different facets to it, all the different care areas, all the different agencies involved. What we're not seeing is that translate into a strategic framework to then deliver improved services. And I'm not sure, we're still trying to work out why that is, whether the people doing the strategy are not lined up with the assessment process or what the reason for that is. But we think that actually aligning those processes better and prioritising dementia within both that assessment and strategy is really, really important. And finally, I talked earlier about the patient or user voice. Health and wellbeing boards, yes, they have statutory responsibilities, and yes, they have to include certain representatives. But I think what we will start to increasingly see is individual ones looking to do things slightly differently. Why shouldn't a health and wellbeing board invite someone with dementia along to a health and wellbeing board session and actually get their user feedback on actually what their service looks like? Is it working? Is it not? Invite a charity or a provider along to actually give their perspective and actually almost hold a mini committee session on the back of that. But actually making health and wellbeing boards dynamic organisations rather than committees is a real opportunity, I think, of the reforms. Information, I think, is also something which significantly needs to improve in dementia services. And this is one of the areas where I think the Prime Minister's challenge possibly isn't quite moving forward fast enough on. There's a lot of money and effort going into clinical research and trials, and rightly so. But where I do think there is an opportunity is actually improving patient information, so actually what information is out there for patients, users, carers for people with dementia. I mean, where do you go if you suddenly find that your mum has been diagnosed with dementia? You may go to the Alzheimer's Society, you may go to NHS Choices, you may go to another site. But actually having that homogenised or done in a structured way would, I think, actually be a significant help to people around their care. I think also providing commissioners with better data on outcomes from providers would actually be a massive, massive boost, and actually trying to define what good outcomes for people with dementia look like, both clinical outcomes but also patient experience, safety outcomes as well, and actually trying to be more transparent around the quality of services that providers are providing would be a significant help to people with dementia and also to commissioners. And actually cancer is a really good example of where actually things like patient experience data, waiting times data, clinical audits have actually done a really good job of driving up transparency around service provision, peer-to-peer learning, and have actually led to improved services. So I think I've covered off most of these, but improved data and information will really help commissioners, they'll really help providers, patients and carers, and actually the public as well, actually, who will start to take in, we saw earlier this week, the maps of death, as the government called them, between different areas of the country about sort of under 75 mortality rates. But this kind of improved transparency and discussion around data will actually improve public scrutiny of services. One of the things that we're championing quite hard is a national dementia patient experience survey. Again, learning from the cancer example being a really good example of that. Across all care settings, asking people with dementia what their experience of care is like. Is it joined up? Is it good quality? Did they get a fully tailored assessment of their needs? Were they offered a care plan? If we can get that kind of level of insight and collection of data, then we'll actually be able to identify where the real issues are and actually start to work together to address them. So that's one of our sort of big ideas which we're championing quite hard. And I'll pass over to Ben, who'll touch on the final couple of points around funding and quality.
So, I mean, we've already talked quite a bit about funding and funding really being the elephant in the room. And my girlfriend's father is a commissioner in South West London, and I was speaking to him about this yesterday, and he said, whatever you do, don't tell them to spend more money because they'll throw you out. So I think, we've really got to recognise that funding is that challenge, and funding is a significant challenge facing the new system and facing dementia services in particular. And I think dementia is an incredibly complex disease, and by its nature being complex, that means the commissioning is complex. And somebody with dementia will bounce across different services, from social care to public health, and then back to the NHS to public health, social care. It's an incredibly difficult thing to actually understand where the money flows and how the money actually follows people with dementia. And I think that's something that we really found from this piece of work, and what was really came across during the roundtable event we held. And I think that's reflected in kind of how some of the commissioning works sometimes. Commissioning can sometimes work in silos. So NHS organisations will protect their budgets and will consider their budgets their own budgets, and will struggle to really look at the individual involved within that commissioning, and actually budgets can work in silos and can kind of constrain and hamper the development of good quality care, and good quality care particularly for somebody with dementia. And then I think, but what does that mean really is that, well, I mean, there is this massive pressure on funding. It's what everybody knows, but actually that does create a number of opportunities, because the squeeze on budgets, combined with an expectation that care's got to get better, means commissioners have got to come together and work out how they're going to improve the quality of dementia care and how they're going to improve the funding arrangements for that. So one of the, again, touching, I think one of the really key areas where this can happen is on health and wellbeing boards. And health and wellbeing boards, by bringing together commissioners from health and social care and the providers who are in their area as well, can really come together and talk about how can the different funding arrangements be improved, and what are the different mechanisms which commissioners can put in place in order to address that. And I think what that really means as well is that it's how can you make commissioners who do develop these innovative forms of funding arrangements, how can they then be rewarded for that good practice, and how can you incentivise commissioners and their providers to deliver better care for dementia and ultimately help them save money whilst at the same time improving outcomes. So there's sort of three key recommendations which came on the back of from our report and from the back of our roundtable. I think the first one is really crucial, is this idea of multi-year budgets. Now, Baroness Greengross, who chairs the APPG on dementia, one of the key things she was saying is that actually the way councils particularly work their budgets, they do it on a year-on-year basis. Now, somebody with dementia doesn't go through their care on a year-by-year basis. Their care is going to be long-term. So the idea of actually councils and the Department of Health working with councils to trial this idea of multi-year budgets into when councils actually begin to plan their social care needs and their NHS needs on a multi-year basis could really help to integrate the funding arrangements. It will also make commissioners have a bit more forward thinking when they're planning their services. I think the second idea is really around pooled budgets. I mean, we've heard for years and years and years that pooled budgets are the solution to everything, and they really do create an opportunity. There is a crucial opportunity with pooled budgets now because A, because of the funding squeeze, but B, because the health and wellbeing boards create this opportunity where pooled budgets can be properly discussed, and where they can be worked up and worked together with the different commissioners, but the providers can also be involved in those conversations, and there can actually be a way of actually rolling these out further and actually demonstrating the good practice examples we're already seeing, but helping to spread those across the country. And then finally, what I touched on earlier is around when savings are delivered within dementia care, how can we make sure that that money which is saved is then funneled back into dementia services to help with prevention and helping to drive up quality in other areas. And then finally, quality and user involvement. You only have to read the Daily Mail every other day, and it does a story about how dreadful NHS care is or how dreadful social care is. That is recognised. There is a real variation in the quality of care older people, and particularly people with dementia, are receiving. But actually, how are commissioners responding to that? Well, I think, as Rich is saying, there is a real opportunity that actually getting greater user involvement through a patient experience survey, but also through surveys and other such mechanisms to actually inform what does good quality care look like for somebody with dementia, and how can that be driven up into the commissioning practices. And, user involvement and quality is really, again, at the heart of the government's reforms. Andrew Lansley has tattooed in his brain this idea of no decision about me without me. And it is really a key lever and a key element of the government's reforms and a key expectation of how the government sees NHS and social care services looking in the future. Now, for dementia, that creates a real opportunity, because of the size of the dementia community and people affected by dementia, but actually because dementia is such a personal disease, it's people with dementia who know what the best kind of care they sometimes need. But in getting people affected by dementia involved in commission decisions, I think really does create a number of opportunities for how local services can be improved. And then I think another element touches around the quality agenda. Dementia was very fortunate that Dementia had the first ever quality standard developed by NICE, and it is really sets out a really positive framework about what good quality care looks like for somebody with dementia, particularly in an NHS setting. Now, that framework is an increasingly important tool because the government expects quality standards to be implemented across the board and to work both from a patient perspective in terms of patients understanding the quality they receive, but also from a commissioner perspective, understanding the type of services that should be commissioned. But looking at how that quality standard actually being implemented is where the opportunity lies, but also where the threat lies in terms of commissioners not following the practices set out in the quality standards and then being held to account by local government, but also by national government too. So the two key areas key recommendations to emerge from the report and our roundtables, particularly around commissioners monitoring how the dementia quality standard was being implemented. Now, this was particularly stuff that the South West were really keen on doing in terms of making sure that everyone across the board within their local health economy was aware what this dementia quality standard was, what it expected, and also, more importantly, looking at how it was being delivered. And then secondly, providers need to have a role in playing that as well, and providers need to be around that table and actually making sure that their own service specifications, but also their own services, are meeting the national quality standard expected of them by government and also by NICE. So wrapping up in terms of what does this really mean, and we're really keen to get some questions and get a short discussion going in the time we've got remaining, but I think, the context is depressingly challenging, and it is an incredibly tough environment out there, and the structural upheaval, a funding squeeze, but also increasing demand. And I think talking about increasing demand, not only the number of people with dementia rising, which it is, but also the fact there's an increasing expectation on commissioners and on providers to deliver better care. And the Francis report even backed that up even more so, that there's a huge pressure that the NHS should be doing more, but at a time when it hasn't got as much money. That said, I think what the report sets out and what we've talked about today is that the reforms do actually create a number of opportunities against this backdrop of challenges, and capitalising on these opportunities and capitalising on what the new system looks like is a way where we can actually see real improvements in the care people with dementia are receiving. And then I think ultimately it's that line at the end. It's whatever we think of the reforms and of Andrew Lansley as a human being, we can make these reforms work for dementia. And if we do that now, we'll see the improvements in the long term. So that's our presentation, and we'd welcome any questions and a discussion.
Thank you very much. We've got time for a couple of questions. We've got a microphone, so if you want to wave your hand and we'll bring it to you. And can I just say that there's another example of a very good report from the Alzheimer's Society. They do produce some very helpful stuff for professionals and for the public and people with dementia and carers. Yes, could you say who you are, please?
Ms. Makandu, I'm a retired NHS professional. I was very interested, the talk was excellent, and it highlighted existing problems. I've recently come from a meeting from my local council. I live in Southwark, and they are rolling out a program called Champion. I don't know whether you've heard of it. And basically, they are training people within the council, and the first topic they're dealing with is diabetes, which again is a huge problem. So what they're doing is they've asked a few of us to come for lessons. So they've selected a few of us, and they're going to train us how to look after diabetic patients. But I think the same program will fit in beautifully with your
Yeah.
elderly care program, because
Yeah.
I think if we can teach the local people, which means family members, to manage, because it's daunting, isn't it?
Yeah.
Everyone here, someone got dementia, even the earliest symptom of dementia, everyone throws their
Yeah.
hands up. So we need to stop that.
Yeah, definitely.
We need to make them feel that, yes, this is something that happens and we can cope.
Yeah, that's absolutely right. And I think actually a lot of what the Prime Minister's Dementia Challenge around this idea of dementia friendly, which is quite a fluffy term and doesn't mean a lot to an awful lot of people. Actually, the principles behind it are sound. And my grandfather had dementia, and when he got diagnosed, I said to my gran, "What should we do?" And she said, "Ignore it, because we can't do anything about it. We've just got to let it go." And actually, that's wrong. It's about managing it. It's about understanding that dementia is an incredibly personal disease, but it isn't. As much as it is daunting, there are loads of opportunities in how care can be managed better, and it's around making sure that commissioning of practices is done better there. So that idea in Southwark is really interesting, actually, that they're doing that, and we'd be quite interested to hear a bit more about it if that's possible.
It's called the Champion Program.
Okay.
Thank you. There's a gentleman here and then somebody at the back I can't see.
Hi, I'm Andrew Pickup with Optilis. You put out some big numbers there, 23 billion. We all know that that's a big part of the problem we're trying to deal with here. With the work you've done, is some of the answer that there's going to be potentially a large portion of savings? And I wonder if you could identify within that savings, what is the first thing that should be done that begins to solve that problem in the largest and easiest way?
Yeah, I think the main area, one example of savings, I think savings could, the work we did, the conclusion was savings can be saved across the board. There's loads of different locations where savings can be saved across the pathway. The one that Richard touched upon quickly was around emergency admissions to hospital, so for somebody with dementia. Now, if you're admitted to hospital in an emergency, that can, in many occasions, mean there's basically been a failure of care, that something's been amiss. You've either had a fall or whatever the problem has been. And our report found, and I'll try and get the figure out, but the report found that significant savings could be found by actually reducing the number of emergency admissions for people with dementia. How do you do that? Well, you make sure there's better provision of community care. There's reablement services available. There's telecare. There's all those sort of things which need to be invested by councils in the beginning, which can later see the return in savings for the NHS in the longer term. Now, this is the issue, though, because the social care services problems cause, or the failures of social care will cost the NHS money. So what we really want to see is a budgets being pulled better, but also more proactivity and a recognition that early intervention for people with dementia can deliver one of those savings. But the report does highlight a couple of examples where savings could be found. And that 23 billion figure also covers societal costs as well, so it's not just to the NHS as well.
Okay, I'm really sorry, but I think we're going to have to call it a day here because we need to enable people to move to the next session. So can I ask you to thank our speakers again?